Welcome back. This is the final lecture on the series of bones, and in this one we're going to look at specific bones of the skeleton. This is not going to be in detail like a lab where you're learning the names of them. I'm just going to talk about some of them generally. So when you're looking at the skull, there are like 8 different bones up here in the cranium and 14 bones in your face. So you've got about 22 different bones, okay? So if there's a right and a left, I'm only counting that as one bone. Okay. So all these bones go together to make this whole thing called the skull or the cranium, and includes the mandible in there. And in that skull, there were 85 different openings. And so in lab, you are going to learn a few of those openings, but anywhere close to even half of those openings. And those openings are important because blood vessels or nerves travel through them. In addition to that, you learn that in 4 of the bones, there were air-filled spaces known as sinuses. And all 4 of those bones, the sinuses would open into the nasal cavity. So those are called your 4 paranasal sinuses. Looking at the floor of the skull, it is not flat. It actually has 3 different levels, and each one has a shallow depression. So we have 3 different cranial fossa. In children and babies, specifically when you were born, the skull is not completely formed, and the flat bones of the skull can actually overlap slightly at the time of birth, making the ease coming out the birth canal slightly easier. And so babies are born with soft spots, and these are the fontanelles. There's a large one here anteriorly, and then there's another pretty significant one posteriorly, but that one closes earlier. And then the hyoid bone, tucked behind the mandible, is the only bone that does not articulate with any other bone. After that, we have a lot of vertebrae in your neck. You have 7 cervical vertebrae. In your thoracic area, you have 12, each of which is going to have a rib articulate with it. In the lower back area, you have 5 lumbar vertebrae. In the plumber's crack area between the 2 buttocks, there are 5 vertebrae that fuse together to form one triangular sacral area, and then below that you have 3 or 4 tiny little coccygeal vertebrae in your tail. Okay. And you can recognize vertebrae by looking at them from above. The cervical vertebrae are the only ones that have 3 foramina in them, and there's 2 special ones. The atlas, which is the first cervical vertebrae that the skull sits on, does not have a body. And the atlas, the second cervical vertebrae, has a tooth-like structure which extends superiorly into the vertebral foramen of the atlas. And so that allows you to turn your head and say no. Whereas the articulation between the atlas and the occipital condyle of the skull allows you to nod your head yes. Okay. If from the side the vertebrae only has one foramen, if it only has one foramen and from the side it looks like a giraffe, it's a thoracic vertebrae, and if it looks like a moose, it's a lumbar vertebrae. Realizing, of course, that the noses have to point downward in the animals. And the sacral vertebrae, as I said, is a triangular structure. The other thing that is interesting is if you look at the junction between your thoracic area and your neck area, the spinous process of C7 is quite long. It's longer than the thoracic spinous processes, and so you can easily find that on your body or somebody else's, and then you know exactly what level of the spine you are at. So looking at the vertebral column, each vertebrae has a foramen, a vertebral foramen, and then when they stack up on top of each other and you look at them laterally, you have foramina which are between 2 different levels. So those are intervertebral foramina, and it's through those that the spinal nerves will be coming out later on. And each vertebrae will articulate with the vertebrae that is above it as well as the vertebrae that is below it. There are all these little facets, which are these smooth little areas of articulations. And for those, if you go back to here, you can clearly see it like on the ears and the jowls of the vertebrae. Okay. And through the vertebral foramen itself, that's where the spinal cord goes. And the last thing is between each of the vertebrae, there is an extra piece of cartilage, which is an intervertebral disc. So let's talk about that disc for a second. So we don't have a disc between C1 and C2 because if we did, we would not have nearly the flexibility. But starting between C2 and 3 and all the way down to between L5 and the sacrum, there are 23 different discs. And these will actually help absorb shock in the body weight while you're in the upright posture. When we look at it, it's not perfectly round. It's going to have the same general shape as the body does because it fits exactly on the body. It does not hang over and there is no space where it's bone on bone. You're always going to have an intervertebral disc. There are two parts of the intervertebral disc. The center part is called the nucleus pulposus, and you need to think of that as kind of like a rubber ball, okay? So when you get out of bed in the morning, it's beautiful and round, and then during the day, it can flatten out slightly due to the pressure coming down on it. And what keeps the rubber ball from completely flattening out is the fact that it is surrounded by several lamina, several lamella of fibrocartilage, and that part is called the annulus fibrosus. So the picture on the right shows all the different layers of the fibrocartilage surrounding the nucleus pulposus. And there's a couple of different types of cartilage involved, and I want you to realize that the cartilage closer to the outer edge is actually the type that is stronger and can withstand even more forces. So this is meant to keep everything in place. So the annulus fibrosus, a bunch of cartilage, the nucleus pulposus, this is like that rubber balloon. It's very gelatinous, has a lot of water in it. However, as you age, the amount of water decreases, which actually makes it a little bit more fragile and more likely for you to have problems with it. So here is a side view showing each vertebra has a little piece of hyaline cartilage, and then we have this intervertebral disc with its two parts, and then you're at the next vertebrae, which has its own hyaline cartilage, because as you recall, every articulation, the bones are going to have hyaline cartilage. So the intervertebral disc, even though it's fibrocartilage, it is not replacing the articular cartilage. The articular cartilage is still there. So the discs are located between the bodies of the vertebrae, and then the spinal cord is in the vertebral canal and the vertebral foramen, sorry. And then what happens is the spinal nerves come out through the intervertebral foramina. Now, when you have a ruptured disc, these center pictures are showing what's happening, and that is the annulus fibrosus is tearing, and that is allowing the nucleus pulposus to kind of like smush out in that area. So that girdle of fibrocartilage has been torn, and so the more gelatinous nucleus pulposus can go out, and you notice we have contents which are now lateral to the body of the vertebrae. And what they're going to do is they are going to be impinging on the intervertebral foramen where the spinal nerve is, as you clearly can see in this picture where you see the nucleus pulposus exiting through the ruptured disc. Okay. So if you're an older person and you jump down off of a height, off of a wall of a fence that you used to do when you were a child, it was fine. There wasn't that much weight behind you. Plus, these things were young and much more flexible. You do the same thing when you're in your 40s. This has dried out significantly, and you're much more likely to rupture because you have a lot more force and a lot more weight going on there. And so when it pushes on the spinal nerve, that is going to give you either sensory and or motor problems for whatever part of your body is innervated by that spinal nerve. All right, so moving on, in addition to that, we had the thoracic cage. And so the thoracic cage basically was made by your ribs, which their head and the tubercle are both articulating to a thoracic vertebrae. So the head actually articulates to the body of the vertebrae, and the tubercle articulates with the transverse process of the vertebrae. And then the vertebrae comes out anteriorly, and then anteriorly it's going to articulate with costal cartilage. Unless, of course, it's the 11th or 12th rib, the floating ribs, which do not articulate anteriorly with anything. All right, so now I need to talk about the pectoral girdle for a minute. This is what attaches your upper extremity to the chest. We've talked about it previously, and we've also talked about how the pectoral girdle, if we look at that glenoid fossa, is very shallow. So it would be easy for that round head of the humerus to disarticulate in almost any direction. And so to try to help hold it in place, we have a group of muscles known as the rotator cuff muscles. And so basically these are muscles which are cuffing around that. So if they're anterior on the scapular, they're going to go anterior on the humerus. And if they're posterior, they're going to go posterior. If they're superior, they're going to go superior. And so it's just trying to hold it into place. And so you're going to learn about those in lab pretty soon. In the upper limb, we had multiple bones. We learned about how the trochlea of the humerus fits in the trochlear notch of the ulna, and that's giving you that hinge joint at your elbow. And then we also talked about the two bones in the forearm, how the radius is rad. It's on the thumb side, and so anatomical position, you have to have your forearms anterior. And the reason for that is when you supinate your arm, when you turn it this way, even when you're just slightly turning it, what happens is the radius will cross over the ulna, so they're not parallel to each other. So there's pictures of that on this slide. Then we talked about how the coxibone is 3 bones which have formed as a child and fused into one large bone for stability. And when we put 2 coxibones, a right one and a left one, together with a sacrum posteriorly and a pubic symphysis anterior, that gives us a complete bony ring, which then can bear the weight of the entire upper body and torso. And then from the pelvis, we will have the lower extremities attached. Looking at the male pelvis versus the female pelvis, the male is definitely narrower and has thicker bones courtesy of testosterone. And if we look at him, the coxal bones are much more upright. What happens at puberty when you get estrogen, that causes the coxal bones to tilt out. And so the female pelvis is much wider but shallower than the male pelvis. And that is why women cannot wear their boyfriend's or their husband's jeans, because his pelvis is like this and hers is like that. There's many other differences between male and female pelvis. If you look at the sacrum in the male, it's very narrow and long, whereas in the female, it's wider. That contributes to the wideness of the female pelvis. We want the female pelvis to be wide so that the baby can fit through and the head can turn 90 degrees and go through as well. One of the big differences is looking at the subpubic angle. And in the male, this is 90 degrees or less, whereas in the female, it is much wider. It's 110 degrees or higher usually. And so there's a couple more pelvises over there, so you can look at those same angles on those. So the pelvic brim and the pelvic inlet are important landmarks. If you go across the ridge of the coxal bone and then right across the top of the sacrum, that gives us this circle, this blue circle that is known as the pelvic brim. And so that is right here, the top of the coxal bone to the top of the sacrum. It is like represented by this blue line right there. Also known as the pelvic inlet, because if you would put a piece of plastic or something at the level of the pelvic rim, if you are above it, you are not in the pelvis. You are still in the abdomen. You're below the levels of the tops of your hip bones, but you are still in the abdomen. You have to be below the level of the pelvic rim to be in the true pelvis. And so when you are, if you are pregnant and they talk about the baby has dropped or the baby's head is dropped, what they mean is the baby's head is finally in the pelvis. Because as long as the baby's head is not in the pelvis, the baby is not coming out down below. And so the baby usually drops a couple of weeks before labor starts. Then we had a lot of lower limb bones, and what was important to realize is the weight was coming down here, and it wasn't coming in a straight line going down the femur, so it came at an angle, but then the femur sits flatly on the tibia, and that is going to bring it to the tarsal bones. Which brings me to the last big topic, and that is to talk about the arches in your feet. So one of the things that was a really significant discovery, or not a discovery, something that they made, and that is the Roman arch. Before that, if you wanted a door or a window in a building, you had to have a big beam, like a big piece of wood that went across the top, and then all the weight would sit on that one beam. But what an arch does, it allows you to have a lot of small pieces, and then you put one tiny little triangular shaped capstone right in the middle. So all the weight comes down and then gets distributed among the arch. And so this is what happens actually in the foot with the 7 tarsal bones. So you know that if you were to trace your foot, it would not have the same appearance as if you step in water and have a footprint. So if you were to trace your foot, it would not have this slight indentation laterally, and it would not have this big indentation medially. And the reason why you have those indentations has to do with the arches in your foot. So in your foot, we have 3 different arches. We have a slight arch on the lateral aspect, which gives us this little indentation. Most people have quite a high arch medially. When you're younger, it tends to fall as you age. And so that gives you the big indentation on the medial aspect, or the big toe side. In addition to that, if you look at the top of your foot, it is not flat like this. It is actually arched between medial and lateral. So that is your 3rd arch. You have arches going proximal to distal, a shallow one laterally, a high one medially, and then you have the 3rd arch going across the top. So why is that important? Here's what it enables to do. All your weight is coming down on your tibia, and from your tibia, it's going to the talus. And if you didn't have these arches, all your weight would be right here in this one point of gravity, where your calcaneus would be hitting the floor. Now, I don't know if you've ever tried to walk just on your heels and bring up the balls of your feet and your toes. What you'll find is you're a lot less stable. Okay. So what the arches do is when the weight comes down, it allows it to distribute the weight, not only posteriorly on the calcaneus, but also distribute weight anteriorly towards the head of the metatarsal bones. And so what that does is it brings your center of gravity from back here, it brings it anteriorly about an inch. And now you have 2 points of stability. And so that's why walking barefoot and walking in flat shoes is a lot more stable. Now, ladies and gentlemen, let's talk about what happens when you put those 4-inch stripper heels. They give you a sexy looking calf, but where is all of your weight going? If you notice, it's coming right down the tibia, going to the talus, but it's not going to the calcaneus. It is going all the way down to the heads of your metatarsals, thus giving you more instability and putting your weight where it was never meant to be put. So think about that the next time you want to wear those really high heels, like for your wedding. Okay, just wear the flats, be more comfortable, have a lot more stability. And with that, we are done with bones. I want to thank you for all your hard work, and I will see you again soon. Have a great day.